Yeah, thank you very much for your kind introduction, and thanks, Professor Riemann, for inviting me. It's a great pleasure to have opportunity to present lung cancer screening, Czech lung cancer screening here. But we are also part of SOLACE project, and we were, I think, one of the first who joined this project. So what is the basis for our lung cancer screening? And we have national, the country-wide program. So this was the cancer mortality, which was like in other countries, the highest mortality within the malignancy. So this was a high priority issue. So you see in 2022, the incidence, there was 6,800 cases per year with mortality nearly 5,000 individuals, and prevalence at the end of the year was more than 15,500 of inhabitants of the Czech Republic. You see increasing prevalence in the Czech Republic, but it is not due to the increased incidence, but it's also due to the improved treatment of the stage 4 lung cancer, and we have available all the new treatment modalities which are on the market currently. So what are the trends? So you see, as in other developed countries, there is a decreasing number of new cases, incidence and mortality in male, but in female you see this is significant increase yet in the lung cancer. So it's a bad message, but it's the late effect of emancipation of women starting smoking heavy 30 years ago. So this is the toll for it. And you see there is different situation in different parts of the Czech Republic. This is the whole Czech Republic. And we have the different incidents and mortality in different parts of the Czech Republic. What are the time trends? Mainly with, I think, improving diagnostic and PET-CT in everybody in diagnostic process, the stage 4 is increasing. So the metastatic disease is seen more frequently. The stages which can be operated are only at about 15 to 20%. And this is the population-based survival of lung cancer. You see that overall it's about 15 to 20%, and in stage 1 it's something more like 60%, but in 4 not reaching 10% in 5 years. So what was our design to program the lung cancer screening? So we started to prepare it in 2019, like Czech Pneumologic Society, and I was the president of the Czech Pneumologic Society at that time. And we have defined the population, and with the help of Ministry of Health and National Screening Center, we have created a protocol and offer it to the Ministry of Health. And after 2 years, it was approved, and in 2022, we were able to begin. What is important to have data, so data how we are doing with the lung cancer screening. And Czech Republic has big advantage. There is a law on electronic healthcare and sharing the data. So we have very nice feedback of what we are doing. So we have data from the National Health Registry, from health insurance companies, healthcare providers. We have pneumologist records and radiologist records, and we have also socio-demographic data. So we have all data which we need for how to define survival, every step in the care of the patients. We know radiation, which drug was taken, the survival of the patient. So we know everything about them. So if they have comorbidity and whatever. And as I told you, we began in 2022. The target population, the Czech Republic, are the men and women 55 to 74 years, at least 20 pack years, former or current smokers. And low-dose CT is initially repeated after 1 year and then after 2 years. We were happy that we were also at the kickoff of the EU initiative for implementation of lung cancer screening in Europe, because at the time of this decision, Czech Republic was the president of EU, so we were able to influence the decision of the European Commission, and we have in fact invited with ERS and Joanna Korostovska was the one who approached me. We invited European commissars, and we have persuaded them to vote for implementation of lung cancer screening in European Union and let the program Solace start. So this is a structure of our program in the Czech Republic. So the main physician is GP. We have 4,500 GPs, and then the specialist who takes care for the patients during the process is lung physician, respiratory physician. We have nearly 300 respiratory physicians, and they are involved all. And we have 43 accredited radiologic centers follow those CTs. So the people are addressed by GP, then go to the respiratory physician. There is measurement of lung function and plain chest X-ray, because if there is any gross pathology, the individual is directly going to the regular diagnostic process. Then the low-dose CT, and in the case of negative, the person is returned to the screening process, and if positive, it's solved in the pneumo-oncosurgical centers, which are all equipped by robotic surgery. And there are all the means of diagnostics and also treatment for the lung cancer. According to accessibility, we tried our best to have nicely covered all the Czech Republic, so that the time to travel to the radiologic center is less than 60 minutes in a majority of our region, of the Czech Republic. And until the end of 2024, there were 33,000 individuals approach. You see, half of them declined. This is something which we would have to solve, because we must present lung cancer screening in different way, like lung health check or cancer screening. Then the examination and the pulmonologist, more than 20,000, and low-dose CTs, nearly 15,000. And we have reached about 11% of the estimated target population. The majority of the individuals were approached by pulmonologists, and we hope that the number of GPs involved will be increasing. Yeah, now you see in the beginning it was 23%, now 45% of GPs are involved. So this is the curve of increasing of involvement of the GPs in the program. Smoking cessation is part of the lung cancer screening program, and in fact we had to promise to our Minister of Health that it will be the part, that we will do maximum to make intervention against smoking, and it's fully reimbursed and coded in the healthcare procedures, so we also see if it was done or not. GP start with the short intervention, then pulmonologists at extended intervention, and also we can send the individuals to the centers of tobacco addiction. And which is important, the control by the data, access to the data from the healthcare. So these are the results. So we have in the first round 3.7% of positive findings and 7% of indeterminate findings, and those people, some of them even appear in the National Oncologic Registry, and you see that more than one half is stage 1 lung cancer, most of them adenocarcinomas. We have also incidental findings, not only pulmonary but also extrapulmonary. So you see that we have 3% of ILA, fibrotic ones, bronchiectasis nearly 9%, emphysema 27%, and coronary artery calcification more than 50%. What is interesting, so we have also looked at those who denied the access to the lung cancer screening program, or those who have already positive finding at the beginning. So you see the stages, because some of them within 6 months appeared in the National Oncologic Registry, and you see that they were at 40% at stage 4. We had also sociologic survey. Based on this, we will take some measure to increase motivation for participation. These are the barriers addressed. And what we have now is a EZ card. This is electronic application. Everybody can make appointment at screening in electronic way. This is mobile app available for everybody. And moreover, we have already legislative norm for lung cancer screening. The first one was on ILAs. It was issued 2025. It's supported by Ministry of Health. And we will have at the end of April also the recommendation for the lung cancer screening, including all incidental findings, also the extrapulmonary. We have website, Prevence pro Plíce, so lung prevention for everybody. And we also presented not only at ERS and European conferences, but also at ATS with quite great interest. We will take the data again to ATS, to Orlando this year. So lung cancer screening, I think this is efficient. We will do our best to increase recruitment of the individuals at risk and try to improve quality and support the SOLIS project, hopefully the SOLIS Plus, which maybe we will be able to follow our way in implementation of lung cancer screening. So thank you very much for your kind attention.